Hello, I'm Dr. George Bacris. I'm one of the chairs of the Cardiometabolic Health Congress. And right now, I want to focus on the Cardiometabolic Health Congress West, where we had a superb meeting, covered a number of topics. And one of the main topics, which is very important, is heart failure. And to discuss heart failure with us at the conference was Dr. Clyde Yancey, professor of medicine and chair of cardiology at Northwestern. And Clyde, I'm wondering, could you recap some of the high points in the advances in prevention and treatment of heart failure?
Dr. Bacris, I'm delighted to work with you today, and let me reach out to you personally and say it's just been a joy for all these years to be in your space and to work with you and to bring so many thoughts to fruition. I go way back with you, and so it's been an absolute pleasure. And thank you for the opportunity to work with CMHC West, because that really was a remarkable meeting. We are at a moment in time that we should all put as a check mark on our calendars. We have been on an iterative development and discovery process in the treatment and prevention of heart failure for at least the last 20 years, with a number of breakthrough discoveries that have been important clinically, but never before have we had a tool as powerful as we have right now. The sodium glucose cotransporter 2 inhibitors really may be the eureka moment that we've been looking for in cardiovascular medicine. That is to say, we know that these drugs help prevent heart failure. The most recent data that we have since CMHC West validates that these drugs treat heart failure. And more importantly, we know that these drugs attenuate, mitigate the progression of chronic renal disease. This is unbelievably important because we know that these findings now supersede anything relating to glucose lowering effect. Yes, they work to lower glucose. And yes, the first observations were in diabetic patients at risk for cardiovascular disease. But now we know that patients with a cardiovascular disease risk or burden, those with renal disease, particularly with diabetes, benefit tremendously. Let me just put this in clear terms. When I was a resident physician at Parkland back in the 80s, one of the worst circumstances we would ever see was the diabetic patient with progressive renal disease. That was a challenge. It was an almost certain mortality. That is no longer the case. When I think about the patient with the trioca of obesity, hypertension, and diabetes, where research that I've published has said that is an aggregate risk of heart failure that accelerates the likelihood of developing the disease by about 20 years. I know that those data are obsolete, and I'm delighted they're obsolete because the use of the sodium and glucose cotransporter 2 inhibitors has greatly attenuated the likelihood of developing heart failure. George, I've been studying heart failure, writing about heart failure, writing guidelines about heart failure for most of my 30 years as a cardiologist. The idea that we're at this moment, this bookmark moment in our careers, where we can say we've discovered a way to fundamentally prevent this disease, in addition to lifestyle and blood pressure control, by adding the sodium glucose cotransporter 2 inhibitors to a medical regimen intended to prevent. And let me just say, no matter how many discoveries we have in the treatment of heart failure, not getting it is where you want to be. And if we can fundamentally do that, this is a very different narrative. I mean, a very different narrative than any I would have suspected, even just a year ago, George. This is fundamentally different.
There's no question, Clyde, that you're absolutely right. And the impact of this class of drugs on the heart, for sure, has been huge, but also on the kidney. Let's not forget that. One of the other things that we talked about in this meeting is the impact of this class of agents on further slowing diabetic kidney disease progression. Obviously, if you help the kidneys, you're going to help the heart indirectly. So this is really kind of put it in the drinking water moments. And
I love that. Yeah.
and we got to discussing mechanism. We got to discussing a number of things that were very much related to this. And I think we have to concede, even though we don't exactly know how they're doing it, they're doing it.
Exactly.
And, um, it depends on the attitude that you have. Some people say, who cares? Other people say, no, we need to know. Okay.
But see, there's another dimension on that, because I can put in front of you the ACE inhibitor, and
Right,
I can put a quarter on my desk and say, tell me exactly how the ACE inhibitor changes the natural history of heart failure. We've
right,
been using ACE inhibitors for most of my 30 years, and
right,
we still can't tell you exactly how those compounds change the natural history.
right,
That's why the evidence base is so important. We want the biological inferences. It helps us connect the dots, if you will. It helps us understand new directions we can go. But make no mistake about it, the data points to which you and I are referring, and for those that are listening, are incontrovertible. Multiple randomized trials are validating these points that Dr. Backrus and I are making, and really are making the argument very profound that the time has come to realize that we're at a pivot. We're at a pivot where we can change the burden of cardiovascular disease, renal disease. And what I really enjoy is that we're having these conversations now. We used to talk about the cardio renal connection. Now we're talking about the renal cardio connection, because when we're doing things that changes the homeostasis of the kidney, you know what? That helps the cardiovascular homeostasis get better as well. When we prevent that primary insult to the kidney, we prevent that burden of cardiovascular disease. So this interconnectedness has taken on more momentum than it ever has before, because we've opened up this window of conversation about a drug class that profoundly affects these multiple organ systems. That is an incredibly important discovery that will be a big deal as we go forward.
So, Dr. Yancey, thank you very much. And ladies and gentlemen, this is a beautiful example of what you will get if you come to the Cardiometabolic Health Congress: integrated physiology applied to the bedside and the office. Thank you for your time, and we look forward to seeing you at this year's Cardiometabolic Health Congress. Thank you very much.